Good morning, everybody. This is Dr. Sonia McGowan with Covenant Pediatric Wellness Center. And today we are going to talk about oral restrictions. We're going to talk about lip ties, cheek ties, and tongue ties. So if you have any questions at all, drop them in the Q&A chat box that you'll see on your screen. And as I'm able to, we'll just answer all of those questions. So let's get started. All right. So most of you probably know me, but if you don't, I, again, am the owner of Covenant Pediatric Wellness Center. You'll see my family here. This is on the far left is my husband, Shannon. He's a CPA. He's actually on track for retirement, which is really strange. But he specializes in agricultural accounting. Our daughter Libby is who you see next. She is a musician. She is the music director for the School of Rock program in Blue Valley, Overland Park, Kansas area. So she lives in Kansas City completely independently. She's a little musical prodigy, which makes me super proud. And then we have Rowan, who is 19. He's home for the summer from college. He's really a big reason why the clinic looks the way it looks, because when he was a little guy, as you'll see there, every haircut looked like that. He covered his ears at sounds. He was nonverbal till he was 4.5, and we really struggled to find the help that he needed. And so now this next picture of him below is the day we moved him into college, and he's posing in his dorm room. So he's come a long way. He's doing great. And then we have Ozzy. This was when he finished, he graduated puppy school. He's a sheepadoodle. He's now 8 months old and gigantic. So, kids move out, we get an empty nest, and what do? We get a puppy. So, all right. So, under the roof of Covenant, we do lots of things. So we really specialize in the needs of complex kids. And so, by that, I mean, we do functional nutrition, we do neurodevelopmental exams, we do neurology-focused chiropractic, we do craniosacral therapy, and our goal really is to get to the bottom of why kids are having challenges. So we run lab tests, we do special physical exams to really get to the heart of why a child is struggling so that we can correct it. We also have Covenant Pediatrics. So Dr. Hannah Strong is our general pediatrician. She's developing more and more experience with kids with complex needs like autism, PANS pandas, but then she also just does standard pediatric care as well. We also have the Spot for Tots, which provides comprehensive evaluation and intervention for oral restrictions. And so within that, we do myofunctional therapy, we do craniosacral, we do feeding therapy as well. And then we have our early beginnings program where we really concentrate on prenatal and pediatric chiropractic, craniosacral therapy, lactation consultation, and feeding therapy as well. So while our main focus is on kids, we do have doctors on staff now who see adults for chiropractic and acupuncture. And I also see adults for functional medicine. So if you're an adult and you've got, digestive problems, you're suspicious of thyroid challenges, etc., we can definitely help with that as well. All right, so let's talk about what's happening in the mouth. So inside of our mouth, we have 7 oral frenula. So we have, so when you see labial, that means lip. When you see lingual, that means tongue, and buccal means cheek. So we have lip ties in our upper lip, not lip ties, lip frenula, upper lip, lower lip. And then we have cheek frenula that are upper left and right, lower left and right. And then we have a frenula under the tongue. And so the frenulum is a woven sheet of fascia that's pulled up into a fold. Sometimes it's always the mucosa. Sometimes it includes the muscle as well. And so what happens when there are restrictions inside the mouth, these are congenital, so they are found at birth. And really what's happening is when certain tissues should differentiate or kind of move away, what we'll see is too much connection. So those frenula are too tight, they're too short, and they restrict the movement of the tongue, the lips, or the cheeks. And so when we talk about the actual terminology, so a tongue tie is called ankylosglossia, and it's a congenital malformation of that frenulum under the tongue. It's important for you to understand that it has to restrict the range of motion and the function of the tongue. And so a person can have a short frenulum but have no functional restrictions. In that case, that's not something we would address, right? We would make sure their function is literally optimal. But when kids have no functional deficits, we don't send them for a release. Lip ties, again, are a congenital malformation of the lip frenula. Again, restricts the range of motion of the lips. It could be upper and it can be lower. And then cheek ties, same thing. There's an issue with the way that cheek frenula has differentiated, and it's too short, it's too tight, and it restricts the range of motion of the cheeks. Okay, so I hear all the time where people will say, oh, tongue ties, lip ties, they're a fad. Everybody's getting diagnosed with them right now. It's common. Yeah, it's definitely not a fad, though. Literature says about 5% of the general population has a tongue tie. It is more common in boys than girls by 4 to 1. There is a correlation. If you've heard of a gene mutation called MTHFR, there is a correlation with that. So people who have the MTHFR gene mutation are more likely to have some sort of oral restriction. They're more likely to have any kind of challenge on the midline. So maybe that's a cleft in their lip or their palate. Maybe it's scoliosis. Maybe it's an umbilical hernia. So things that happen on the midline that aren't quite right are generally associated with MTHFR, and oral restrictions are one of those things. And so it's really more than just a simple anatomical difference. And I'm going to show you eventually some pictures of, normal frenula versus restricted frenula. And so it's an anatomical difference, yes, but it's more than that. It can profoundly affect the way a child develops. And so what I see really commonly is I check most every kid for oral restrictions. I've never seen a lip tie without a tongue tie. Now, the opposite is not true. I often see tongue ties without lip ties. So when I see one, I'm always looking for the other, for sure. And so when you think about the development of an infant, the tongue plays a crucial role in their oral motor function, of course. So early experiences with nursing, the way babies explore with their mouths, right? They put hands, they put everything in their mouths. This really drives the formation and the refinement of those nerve connections associated with tongue movement. The tongue is also a highly sensory organ. It provides a lot of feedback to the brain. And so this really contributes to the development of proprioception, or where our bodies are in space. It fine-tunes the motor control, and that really influences broader neurological development. Movement of the tongue really drives a lot of things. So it shapes those nerve circuits, but movement and placement of the tongue also affects how the face is shaped, how the roof of the mouth is shaped, how the floor of the nose is shaped. And so the tongue really is the driver of all development: gross motor, fine motor, skull development, oral development, etc. And of course, the tongue's role in speech production is very, very important. And the way you produce speech is linked to the way you process language in the brain. So if there is a tongue tie, it can't help but affect speech and language development. And then if you've got a restriction in tongue mobility, it will change the way a child develops. So it changes their sensory processing, it changes gross and fine motor coordination, speech and language development. All kinds of broader cognitive functions can be affected, but also, again, that whole development of the face, the sinuses, the roof of the mouth, the mandible, the jaw, all of that is really directly related to the way that the tongue is able to move. So when a child does not have good oral function, particularly of the tongue, we will see issues around breastfeeding, swallowing, breathing, facial muscle control and coordination, as well as the tone of their vagus nerve. Vagus nerve is kind of a hot topic right now. A lot of people are talking about this. It's a cranial nerve that goes from your head down to your intestine, and it really has a lot of control over the way we respond to stress in our environment, as well as, lots of other functions. And so really, an oral restriction is a whole body issue, not just a mouth issue. And so what we'll see is restrictions in the mouth are reflected in other parts of the body. And people are always shocked when I tell them this, but the mouth mirrors the pelvic floor. And so if there are restrictions in the mouth, we will often see issues around a child with toilet training. They'll typically have a much harder time with toilet training. And then as kids get older, we'll see that girls have a lot of issues around their cycles. They'll have, a lot of what we call dysmenorrhea or troublesome cycles. And as they continue to get older, we'll see even things like painful intercourse. We'll see erectile dysfunction in men. And we've even seen, kind of along the whole painful intercourse thing, we've seen lots of women who, because they had an oral restriction, were not able to use a tampon. It just would not work for them until they had that oral restriction released, and then suddenly they were able to use those. Also, the tongue connects the chest and the diaphragm. It connects to the chest and diaphragm. And so when your tongue is restricted, it changes your posture. It changes the way you breathe. It changes the way that you swallow. And so especially, I don't know if you guys are paying attention, but we see a lot of kids, and we see a lot of postural distortion in kids over the last several years. A lot of it is, they've always got their nose in a device, but, we see a lot of kids who slouch and they slump forward. They have kind of a rounded upper back. And so it's really common when we work on oral function to see those postural distortions improve. And so when I said this is a whole body issue, I wasn't kidding. So what you're seeing here is something called the deep front line. So this is a continuous sheet of fascia of the body. It's been dissected away. And so what you're seeing here at the top is the tongue. And remember, this is a continuous sheet of fascia, uninterrupted. And so we see the tongue, we see the lungs, we see the diaphragm, and then we come on down to the trunk and the legs and the knee, all the way to the toes. And so literally, you've got one sheet of continuous fascia that goes from your tongue to your toes. And so you can, when you think about it like this, you can understand how this is a whole body issue, not just a mouth issue. So people ask all the time, okay, so my kid has a tongue tie or a lip tie or a cheek tie. What happens if we do nothing about it? And so these are some possible effects if you choose to not address oral restrictions. So we see major issues around sleep and breathing. So sleep disruptions, sleep apnea, snoring, bedwetting, sometimes teeth grinding in the night. We have a lot of issues around, the mouth itself. So often we'll see orthodontic issues. It's really common for kids with lip ties to have what's called a diastema, or a gap between their two front teeth. And if it's a lip tie causing that, you can get braces, but the minute the braces come off and you fail to wear the retainer, that gap is going to open back up. So a lot of times we'll see a really narrow upper jaw, and that will sometimes require expansion. We see often a high narrow palate, again with the teeth grinding. We see speech issues, a lot of mood problems, hyperactivity, headaches, pelvic floor dysfunction. So there are a lot of sort of far-reaching effects of oral restrictions when we don't work on correcting those. So let's talk about the nursing mother. If you have an infant, a newborn with oral restrictions, maybe you don't know much about it, you didn't think to be assessed for that. That's me with my first child, Libby. moms will have a lot of nipple symptoms. So a lot of times what we'll see are creased or flattened or blanched nipples. We'll see nipples that are lipstick shaped, that are blistered, bleeding. Um, we'll see just really ineffective breastfeeding. So poor or incomplete drainage of each breast, a lot of infections. And it's really common to see babies who only want to nurse on one side. And moms will tell us feeding this baby feels like a full-time job because it's more difficult than it needs to be. So in the baby, the kind of symptoms that we're looking for, we often, before baby is born, we'll see some positioning challenges. So babies who want to remain breeched, who don't want to go head down. Really, really common to see hiccups in utero. And when mom goes for ultrasounds, it's very common to see baby consistently keeping their hands near their head. Once baby's born, we tend to see very excessive crying, what looks like colic, lots of, spitting up, projectile vomiting, babies who don't gain weight very well. And a really common and important sign is that their nose is often congested. And then they have a lot of nursing and feeding challenges. So they don't latch very well. Many times they can't open their mouth wide enough to get a really good latch. They often break that latch frequently or easily. They pop in and on and off the breast. They'll click or smack. They'll leak milk out of their mouths. And when a baby latches, their top lip should really flange up. And what we'll see, particularly in babies with lip ties, is that lip doesn't flange. It sort of curls under. It goes the opposite direction. A lot of times babies will be sort of frustrated, combative. They'll turn their heads. They won't want to nurse. They won't want to take a bottle. Often they can't hold a pacifier independently as well. It just sort of falls out of their mouth. And so here is a picture of another symptom of oral restrictions in babies. We call them lip blisters or cobblestoning of the lips. And you can see that really clearly here. Their lips look like they have cobblestones. And so that is a very strong sign of oral restrictions in an infant. Other symptoms that we see is tongue scalloping. So when we look at a baby's tongue or a child's tongue, we'll see scallops around the edge. Or like this child, their tongue will cup up when they're crying. We'll see lots of colic, lots of irritability. They can't be consoled. They're hard to soothe. Also lots of ear infections as babies continue to grow. There is a muscle kind of at the posterior backside of the tongue that is connected to the inner ear. And so when the tongue can't move appropriately, it can't activate that muscle to let those ears drain. We see, so again, the frequent ear infections, we see that thumbs are often tight. Sometimes they'll hold their thumbs inside their hands. Toes are often really clenched and tight. And then we'll see range of motion differences. So kids who can't turn their head equally in all directions, sometimes as babies are learning to roll, they'll only roll to one side and not the other. And so any kind of turning, rolling, any kind of range of motion that's unequal on each side, we definitely want to look closer at that. And when I talked about before the MTHFR gene mutation, they use the term midline defect. I don't like that term, but it is what it is. So these are some of the things you'll see in kids who may have the MTHFR mutation. Kids with oral restrictions may also have some co-occurring midline issues like these things. And so here's a baby who's giving us lots of clues. So this is a baby in our clinic. Those are my hands. So we see the cupping of the tongue. We see the thumbs that are tight and clenched inside the palm of the hand. It's not so easy to see in this picture, but this baby also has pretty significant cobblestoning on their lips. So some more symptoms of oral restrictions in babies. We see head control issues. Sometimes it's too little head control. So their heads are kind of floppy. Their heads lag when you pull them to a sitting position. But even more commonly, we will almost, very frequently see too much head control. So these are babies who are very tight, they have very high tone, and so they're lifting their heads um, in a at an age that's too early to be doing that. It's really common to see resistance to tummy time as well. So these are babies who don't like to lay on their bellies. Laying on their bellies is extraordinarily important for their development, but they really fuss about it. And if you go back to that deep front line picture that I showed you, if you think about that deep front line of fascia, if it's tight, it's pulling you into flexion, right? And so to force a baby to be on their belly, which pushes extension, is going to be uncomfortable for them. So resistance to tummy time is a red flag for sure. And then we see sometimes differences in facial development. This picture gives you an example of what's called a retrognathic jaw. So you can see how their jaw sits back quite a ways from their upper jaw as well. We'll also see issues around asymmetry. So sometimes we see, differences in facial development, how the eyes are lined up. Sometimes, the nose or the mouth might be crooked. We'll also see head shape differences. So, for example, this little gal had quite an issue with the shape of her head. We'll sometimes see what's called plagiocephaly, which is a flat spot on the back or side of the head, and then torticollis is a situation where the head is sort of stuck in a wrong position. So they're stuck in lateral flexion and rotation. So they're like this all the time. And that will also promote the flat spot on the head. And so, again, milestone challenges, frequent ear infections are all really common things that we see. Sometimes we'll see some compensation. So when kids start crawling, for example, they won't crawl on all fours. Maybe they'll scoot along on their bottom. Maybe they'll kind of army crawl. So any sort of compensation toward a normal developmental milestone is a red flag. Sometimes we'll see differences in tongue movement. So we'll see tongue thrusting, we'll see cupping. Here's an example of a baby with a tongue thrust. So the tongue is thrusted forward and rests between the lips instead of resting inside the mouth. We always have a look at the shape of the palate as well. So we try to visualize it, but we also palpate it. And so if we see a baby with a high vaulted palate, we're definitely concerned about that. And then any sort of dental issues. So many times as kids, as their primary teeth come in, especially if they have a lip tie, we'll see a lot of erosion on those front teeth because milk gets trapped and the baby's not able to clear that milk from under their lip. Sometimes we'll see, again, that gap between the front teeth. Sometimes we'll see, inconsistencies in the way the adult teeth will erupt as the child gets older. Dimples are actually a sign of cheek ties. Sometimes they just are what they are. They're inherited, but sometimes a dimple can be a sign of a cheek tie. So if I see kids with lots of dimples, I always have a look at that. And then mouth breathing is a major red flag as well. So as kids get older, we start seeing some symptoms around eating. So kids who are messy eaters, because they don't have a good awareness and coordination of their lungs, their tongue, their lips, and their cheeks, and so it's hard for them to manage food in a efficient, neat sort of way. These are kids who will often dip a lot, so they dip in ranch or ketchup, whatever. And they do that because it makes the food easier to manage in their mouth. It slicks it up, makes it a little easier to handle with their tongue and to be able to swallow it. And same with drinking. So these are kids who sometimes will drink excessively. They need that liquid to organize that food inside their mouth and get it down. Also very common for parents to tell us that these are kids who want to graze. So instead of, eating a full meal at a time, they just want to eat little bits at a time. Because when your mouth doesn't work appropriately, you don't have a good awareness or coordination, strength, stamina of your tongue, your lips, your cheeks. You can choke easily, you can gag easily, and food is really hard to manage, especially foods that kind of break into a lot of little pieces. So think like chips or crackers or things like that. It's hard, or even like broccoli. it's hard to gather up all those little pieces and put them in a bolus to be able to swallow. So kids will spit food out, they'll avoid certain foods, so they want the things that are easy to manage. So a lot of times we'll see, mashed potatoes and mac and cheese and things like that, as opposed to, maybe meat that takes a lot more strength and stamina to chew and organize and swallow. A lot of times these are kids who eat really slowly. Um, Eating for a lot of kids with oral restrictions doesn't feel safe to them because their airway is often compromised, they're uncoordinated, and so eating is a challenge. We'll see some digestive things like reflux, constipation, poor weight gain. A chronic raspy voice is really common. Poor saliva management. So again, they have poor awareness, coordination, strength, and stamina. And so a lot of times we'll see kids who will drool, who will leak saliva. Um, Oral habits is big. So these are kids who hold on, want to keep a pacifier. They want to suck their fingers. They want to suck their thumbs. Everything goes in the mouth. I've seen older kids who want to keep like swizzle sticks or straws in their mouth all the time. And sometimes this is a strategy to protect their airway. Um, Sometimes it's just a coping mechanism as well. And so sleep challenges are big. So we just see so many kids who don't sleep well. And one of the major things I want to rule out are oral restrictions. And so we'll see kids who struggle to go to sleep. They either breathe loudly, they audibly breathe, or they snore. They're restless. They wake up unrested. They grind their teeth. They have nightmares, night terrors, sleepwalking. They breathe through their mouth when they're sleeping. And so one of the things I always do is look at kids' tongues. And so here's an example of tongue scalloping. So you can see kind of the outline of the teeth on the edge of the tongue. And then you see lots of these fissures too. So this is a person who I think is probably not absorbing their food very well. They have a white coated tongue. So I'm guessing they probably have some yeast overgrowth in their intestine as well. And all of those can sort of wrap up together with oral restrictions because, your first step of a digestion is in your mouth. And if you're not very good at that, it's going to have a downstream effect for sure. And so here we go with the open mouth breathing at night. We see bedwetting, we see an open mouth posture, lots of anxiety, attention problems. Because if you're not getting good sleep, your brain is not recovering at night, you're not oxygenating well, and so this can really translate into kids who look like they have attention and focus challenges. So I mentioned postural distortions before. So we generally take posture pictures on most of our patients. And so you can see here, this little gal has lots of posture issues. So a high shoulder, she's got a foot flare, she's got a little twist to her torso. And so this is happening along with some sleep issues and oral restrictions for this child. So in toddlers and kids, as language starts to develop, we may see difficulty producing sounds appropriately. Sometimes kids will revert and use a baby voice instead of a typical voice. Sometimes they're difficult for others to understand, and we'll see things like lisps or omissions of certain sounds. We'll substitute one sound for another, and so sometimes we'll even see kids who will avoid certain words or certain sounds or certain speaking situations because they've developed an awareness that they're really struggling in this area. And so here are a couple of examples of some postural issues, some alignment issues as well. So you can see this little gal, of course, has that persistent head turn with a little bit of a tilt. We can also see here a little bit of structural difference. One eye is a little higher than the other. One side of her mouth is a little lower than the other. And these are both kids with oral restrictions. We do work with adults who have oral restrictions as well. And so it's really common for us to see kind of a forward head posture, other kind of postural distortions, lots of headaches, a body that's very stiff and inflexible. And so here's an example of an older, a late teen who we worked with a few years ago. And you can see just in about 6 weeks of work, of craniosacral, chiropractic, tongue tie release, you can see how much her entire face changed. This is actually my daughter. This is Libby, and of course, that's me. We didn't discover her tongue tie till she was 17. She was having some headaches and some sleep issues, some anxiety, and she came home. She was a barista at the time, and she came home really frustrated because that particular shift, she really struggled. Her brain and her mouth just weren't working very well together, and that is what finally made my light bulb go off that we need to check her for an oral restriction. And she had both a severe lip and tongue tie that we had corrected when she was 17. So lots of things improved for her then. But she had some GI symptoms, troublesome periods. That's what we're seeing a lot in older kids and adults. The other thing that we commonly see is what's called an inferior sclera. So when you look at someone, you should not be able to see the whites of their eyes on this lower margin. And so when you have inappropriate jaw development, what happens is the face becomes longer than it should, and it sort of draws that face down. And so it promotes an underdeveloped maxilla or upper jaw. And so this is highly suggestive of an inappropriate tongue posture, leads to the long face, which pulls those eyes down. So whenever I see an inferior sclera like this, I always check the child for a tongue tie. All right, so let's look at the lip frenula. So these are normal lip frenula. So this child, you barely see any tissue here at all. Here you can see that frenulum, but it ends nice and high. So this is appropriate. This is what a normal lip frenulum looks like, as opposed to a restricted frenulum. So look at this. On this infant, you can see that frenulum has a wide base, and it comes down and it completely wraps around and under the gum line. So this is a baby I would predict, if we had not corrected this, they would have had a large gap between the two front teeth, like this child. So here again, you see that wide base comes down, frenulum comes to the gum line and then wraps underneath. So that is what's promoting that space between the teeth. So again, in time, braces would correct this, but not permanently. It's always going to want to drift because you've got this huge frenulum that's hanging that up. All right, so let's look at the cheek frenula. So here we have upper left and right cheek frenulum. And here are the lower ones, here and here. So here's another example. You can really see how that tissue is short and tight and can restrict the movement of those cheeks. So let's look at the tongue. So underneath the tongue, we have the frenulum. This is an example of an unrestricted frenulum. So that tongue can lift nice and high. We don't see that frenulum is short or tight or restrictive in any way. As opposed to this child, you can see how wide that frenulum is. You can also see, as I'm using that guided director, how that little bit of pressure causes the blanching right here. So it turns very white. So this is a child with a very significant tongue tie. Here are some more. So here is that frenulum, and you can see how difficult it is for that child to lift their tongue because this is so short. And just with the little bit of pressure I'm applying here, you can see how it turns that frenulum so white. And this is a baby with an incredibly short frenulum. Do you see? I can barely even get my fingers under his tongue because that frenulum is so short, and it also extends almost to the very end of the tongue. So here's an older child. This is as wide as this child can open her mouth. So I could barely get my pinky fingers in her mouth and under her tongue. And so when I changed strategies and I used a tool to try to look under there, you can see she cannot lift her tongue to touch the roof of her mouth. And you can kind of, I mean, you weren't there, but you can read into her facial expression. She was very uncomfortable with this. It was not, it didn't feel very good to her. And she was also fairly nervous that it would cause her to gag. So this is little Jackson. His mama works here for us. This was him in the car on his way to having his tongue tie released. So you can see he cannot lift his tongue. When he tries, it's tethered down and it causes his tongue almost to fold in the middle. He was told by his other providers that this was totally fine and it would not affect him. Right? This was him immediately after the release, back in the car, just a few minutes after being done, and you can already see the difference. So he can extend his tongue much farther. He can open his mouth much wider. He still has kind of that heart-shaped tongue, but that has changed over time. This was, I don't know, a year or more ago, and so the shape of his tongue will definitely change. And I can tell you the difference that the tongue tie release made for him was unbelievable, particularly in language, activity level, just language processing, speech, all of it has just exploded for him. And so here's an example of a high, narrow palate. So we're looking, at the roof of the mouth from below. And so remember that the tongue determines the shape of the mouth and jaw. So our oral posture on a regular basis needs to be when our mouth is closed, we want our lips touching. So we want our lips closed. We want the tongue resting on the roof of the palate, and then we want the person to be breathing through their nose easily. And so when you have a palate like this, remember the roof of the mouth shapes the floor of the nose. And so when you have this high, narrow, vaulted palate like this, you're giving less room for the nose to do its job. And a lot of times this will promote mouth breathing instead of nasal breathing. So function is key. It's more than just how it looks. We have to be able to look at the function. So how does the tongue move? How coordinated is it? How strong is it? Not just the tongue, but the lips and the cheeks as well. And we have to, assess how they breathe and, what their motor skills, gross and fine motor, are like, what their language skills are like. So it's a big picture. I have parents who will take a photo of, their child's lip or tongue or cheek frenulum and say, are they restricted? And I have to always say, I'm sorry, it's more than appearance. I have to see them in person. I have to assess them I have to assess their lips, their tongue, their cheeks for all of these things, for awareness, for strength, for stamina, range of motion, coordination, control. All of it is part of the big picture. And so my husband's always like, do you have to work all the time? We're just trying to watch TV. Why do you have to point out all these things about people? So once you know about oral restrictions, you can't unsee it. So here's Meredith Grey from Grey's Anatomy. I swear she has a tongue tie. So she's got that odd little lisp when she talks, but look at how her tongue cups up when she cries, right? She totally has a tongue tie. I'll just call her, hey, Ellen Pompeo, you have a tongue tie. But again, I can't just go by appearances, right? We would have to assess. But yeah, very, very suspicious of a tongue tie with her. And this is the gal from the Gain commercial. So a few things about her. She's got the dimple, so I would definitely want to assess her for a cheek tie. And then she also has that diastema between her two front teeth. So I'm super suspicious of a lip tie for her. All right. So in summary, I have a lot of parents who will come to me and say, oh, my pediatrician says he sticks his tongue out just fine. He can't have a tongue tie. Well, we do a lot more with our tongues than just stick them out, right? And so oral restrictions have major effects on speech, neurological development, motor development, including fine and gross motor. And so any child who has a gross motor, fine motor problem, any kind of sleep challenges, feeding challenges, behavior, attention, speech, any of that, if those kids are struggling with any of those things, they should be assessed for an oral restriction. Early identification, early intervention is best. But they need to be looked at, and by someone who's had the training. So most mainstream pediatricians, dentists, speech therapists, even occupational therapists, have not gotten extended and in-depth training on oral restrictions. You need to find someone, it doesn't have to be me or my staff, but you need to find someone who's had additional training to assess function and structure. And so a child, if they're struggling with feeding, even if they're gaining weight as an infant, they should be assessed for oral restrictions, even if they're gaining weight. And this assessment needs to be ongoing, because we see a lot of kids who maybe as a new infant look okay in terms of restrictions. However, as kids grow and develop and they reach new milestones, their bodies grow, but maybe that frenulum becomes more restricted. So it's not just a one and done thing. We have to just keep our eyes on it all the time. And if a child starts showing symptoms, even if we ruled out a tongue tie as a tiny baby, now they're 18 months old and struggling with whatever, we will assess them again. And so an oral restriction should be considered for all kids, especially who are not progressing as they're expected in terms of milestones, gross motor, fine motor, speech development, anything like that. We don't necessarily recommend an oral restriction release in every case. Sometimes when we do therapies to get them ready for a release, like chiropractic adjustments, craniosacral, in some cases massage, things like that, feeding therapy, myofunctional therapy, sometimes that is enough to improve their function to the point where we agree that a release is not needed. So it's really individualized for every child. And we have very trusted providers who we send our kids to for their release. Dentists who are very highly qualified, highly trained, and skilled at what they do. And I'll tell you, the differences we see in kids who have a significant restriction and we send them for a release, it's amazing to see how their development just explodes when that release is over. So here's our contact information. We have quite a large staff now. We're in Jefferson City, Missouri. We have chiropractors on staff. Again, we have our medical doctor. We have a lactation consultant, physical therapist, and occupational therapist as well. And we're really the premier place to go if you are concerned at all about your child's development and oral restrictions. If you have any questions at all, we're always taking new patients. You can call our front desk. Our number's here. You can also email us as well. So don't hesitate. If you have questions, if you're just curious, if you want your child to be assessed, we're very skilled at that. And again, we're always taking new patients. So there you go. That's a brief look at oral restrictions and how it can impact development. So I thank you for joining. If I'll give just a minute here, if anybody has any questions that you'd like to ask, I'm happy to answer that. Otherwise, I will let you get on with the rest of your day. So last call for questions. Any questions at all? All right, great. Well, if you need anything, if you have a question after the fact, feel free to email me, Dr. Sonia at covenantwellness.net. And we have I do a webinar every month. Generally, it's the first Friday of the month. But because of the 4th of July holiday, I backed it up. So it's today instead of next week. But in August, we have another webinar, and I should have looked for this beforehand. So the August webinar will be August 2nd. Generally, again, it's the first Friday. And so be watching social media. We always announce that about a couple weeks ahead of time. We always offer the replay for the people who have registered. So, and then if you're interested in any of the previous webinars I've done, you can go to thewhymatters.net and then click on the webinar series, and you can see all of the past webinars that I've done, and you can watch them anytime, as many times as you'd like. Um, so again, thanks so much. I hope to see you at the August 2nd webinar. And if you have any questions, just call our office or shoot me an email. All right. Thanks, guys. Have a great day.